Good afternoon, everybody. Thank you so much for being with us this afternoon. My name is Tony, and I'm an assistant dean in Hofstra University's School of Health Professions and Human Services. It's an absolute pleasure to have you with us for this evening's State of Hope event titled Elder Care Options Beyond the Nursing Home. Our event will begin at approximately 4:05 p.m. We just want to give everyone who has had the opportunity to register for this evening's event the ability to sign on. And as I say that, I see more and more people joining our Zoom. For those of you who have joined us just now, my apologies. You will hear me say this announcement probably 2 or 3 more times. But we just want to give everyone the opportunity to sign on who has registered. We will begin at approximately 4:05 p.m. Good afternoon, everyone. Thanks again to those who just joined us. My name's Tony. I'm an assistant dean in Hofstra University's School of Health Professions and Human Services. It is our absolute pleasure to have you with us for today's State of Hope event titled Elder Care Options Beyond the Nursing Home. Our event will be beginning at approximately 4:05 p.m. We just want to give everyone the opportunity who has registered for this event to sign on. So you may hear me make this announcement 1 or 2 more times. All right, everybody. Thank you once again to all who have joined us for this evening's State of Hope event. My name is Tony Porcelli. I'm an assistant dean in Hofstra University's School of Health Professions and Human Services. As we are about to begin our evening's event, I will ask that everyone keep their cameras off and their microphones on mute for the duration of the event, so as to allow our panelists the ability to not only present, but to also offer responses to questions you may have. In the chat, I'm going to put in some direction for asking questions. If you have questions of any of our presenters, we ask that you submit them within the chat. These questions will be reviewed and moderated by the Honorable Kemp Hannon, the facilitator of our event, once all speakers have had the opportunity to present. In addition, I welcome all of you to follow the School of Health Professions and Human Services at Hofstra University on our social media channels. We can be found at H.P.HS. Now, it's my absolute pleasure to welcome the Dean of our school, Dr. Holly Syrup, to offer some opening remarks. Dean Syrup has been a fixture of leadership on Hofstra's campus for over 35 years. Past roles Dean Syrup has held include Executive Dean of Students, Vice President of Campus Life, after which Dean Syrup joined Hofstra's faculty and achieved the rank of full professor in both the departments of counseling and mental health professions and educational leadership. In 2015, Dean Syrup rejoined Hofstra's administration as she was appointed Vice Dean of the School of Health Professions and Human Services, and later the Dean of our school. Under Dean Syrup's leadership, our enrollment has grown in upwards of 60%. We have added a variety of graduate programs, most recently a master's program in gerontology. In 2019, Dean Syrup was named one of Long Island Business News' top 50 women in business, which is a great testament to her achievements in education, specifically at Hofstra University. Without further delay, it's my absolute pleasure to welcome Dean Syrup and to ask her to offer some opening remarks.
Thank you, Tony. And good afternoon, everyone. And thank you for joining us for our 10th State of Hope signature event. It's hard to believe that we're already on number 10. Seems like we just started. The State of Hope series was created to provide an outlet for the community to come together to discuss contemporary issues in healthcare and the impact on current and future policy. Now, Hofstra School of Health Professions and Human Services is proud to be a leader in preparing students to be the healthcare clinicians, providers, and leaders of tomorrow. Our commitment to training emerging professionals to advocate to meet the needs of an increasingly aging population is evidenced by our faculty's active research in this area and their relationships with local nursing homes and rehabilitation centers where many of our students go for clinical internship experiences. Furthermore, as Tony mentioned, we're very proud that we now have a master's degree in gerontology, healthy aging, which is building upon our existing advanced certificate in the area. This is one of the many reasons why I'm so looking forward to today's program, Elder Care, Options Beyond the Nursing Home. The topic is timely and important. According to the US Census data, the population of Americans aged 65 and older is projected to increase from 52 million in 2018 to 95 million by the year 2060. This would represent an increase in the population of the US of individuals over 65 from 16% to 23%. Members of the baby boomer generation may also increase the population in nursing homes, probably by almost 50% by 2030. But at the same time, we're seeing the population in nursing homes increase. We're also seeing a rise in those over 65 opting to age in place, which has resulted in an increased need for at-home care and services. Tonight's panel of speakers are all advocates for America's aging population, and we'll learn from their professional experience, their leadership, and expertise regarding how to meet the needs of the rapidly growing aging population in the US. And we thank them for sharing their insight with us today. And now it's my honor to introduce our moderator, Kemp Hannon, Health Policy Fellow in the School of Health Professions and Human Services. Kemp joined HPHS in April 2019 after a distinguished career in the New York State Senate, where he built a reputation for working across party lines to put the health and well-being of others in the forefront. He continues to do that by organizing and facilitating our State of Hope programs, which allows for an exchange of thought, policy, and practice. It's now my pleasure to turn the program over to Ken.
Thank you, Dean Syrup. Appreciate that. Welcome to the 10th forum that we're having. I had hoped by now in August of 2021 that we might be able to go back in person, especially since it allows for such vigorous conversations and questions at the end. The trade-off is we have some great experts who can come make presentations without having to spend a lot of travel time. And tonight, we're again graced with some really great people. We started out with a sense of just options for the aging beyond the nursing home. And in a sense, it's still options for the aging, but you don't have to be aging in order to be taken care of at home, to get rehab at home, to get infusion at home. So it's really a sense of the non-institutional care that's going on. And as you'll be able to see from the facts that will be presented, it really is some in-depth presentation. We'll start off with Merryl Siegel, who is the Senior Vice President and Regional Director of Post-Acute Services at Northwell. Then we'll go and listen to Carol Waldman, who's been the executive director of the Glen Cove Senior Citizen Center here in Nassau County. And then we'll have Al Cardillo, who's the president and CEO of the Home Care Association of New York. Helping Merryl Siegel is Meredith DeSimone, who's kind of a finance and statistics and other management expert, who's put together with Ms. Siegel a terrific beginning slide presentation. So with that, Merryl, I'm going to cue you up and with Meredith, and hopefully you might start our exploration of these alternatives to institutional care.
Thank you so much. And it's an honor to be here, and I really appreciate the opportunity. Meredith, if you could put the slides up. So as many of you know, Northwell is a large health system in the New York metropolitan area. And we do have 23 hospitals throughout the area. However, Northwell has always really, well, if you can, sorry, has always over the past 20 years been really dedicated to not just providing care in the hospital, but providing care throughout the continuum. So over the past 20 years, we've built what we call the Division of Continuing Care or Post-Acute Services, an array of opportunities for patients, primarily long-term, but really throughout all ages of services that can be utilized after hospitalization and even before hospitalization. So I'll just give you a high-level overview of what Northwell has. We have 3 subacute rehab and long-term care facilities, Stern, Orzac, and Peconic out in Riverhead. We have a large core laboratory service that has services within each of our hospitals, but also a centralized laboratory. And in the lab, we've really also begun to focus on how we can achieve laboratory services for those in the home. We have LabFly, which is an opportunity for you to call and get lab services right into your home. And we've also just acquired a home service where phlebotomists go into the home for those homebound and works closely with our physician practices. We also have a large array of services through Northwell at Home, which Meredith will talk a little bit more about. And this consists of certified home health agencies, a home infusion company, a licensed agency. We have private pay aides, and we also have geriatric care managers, which can assist in accessing all types of services for the elderly. And we've also recently started a rehab at home service that provides rehab services in your home, not just in the outpatient facilities. As many of you know, we also operate 18 STARS services, which are outpatient rehab services provided throughout our geographic area. And we also have outpatient sites at 6 of our hospitals. We also have 4 hospices that we've combined and we're integrating into one large hospice that provides not only in-home hospice services, but we also have an inpatient residence in our in the Melville area. Now, the landscape for post-acute services, if you can flip the slide, Meredith, has really changed over time. So originally, back 20 years ago, these were discrete business entities. They were ancillary services, and they generated high margins. And throughout the years, we always had the decision of whether we grow these services or we sell them to monetize them. But the landscape has really changed over time. We're seeing much more risk-based models that are coming through. We've seen patients leaving the hospital sicker and sicker. And what we really found was that over time, patients really wanted to stay at home. We wanted to meet the market demand for more home-based services, and we wanted to keep patients connected to Northwell. Many of our competing health systems were really focused on hospitals and not really focused on providing the continuum of care and accessing services, particularly for the elderly throughout the continuum of care. So we've aligned with our system. We're moving towards an initiative of preventing readmissions, and we're caring for much more clinically complex patients. Meredith?
Sure. So as Dean Seraph mentioned in her introduction, the population of Americans is aging very quickly. And New York is the third largest aging population in the nation, and that population is expected to grow over the next decade 20+%. You can see here from 1960 through projected 2040, that population is going to quadruple and probably more beyond that. And not only is the population over 65 growing, the percentage over 85 is increasing, as you can see with the yellow portion of the bar graph. So we're asking ourselves, what is this population going to need? And what is their demand for services going to be beyond the traditional custodial long-term care that's been what is offered to patients as they age? Are they going to want things like an assisted living at home where they can age in place independently and bring the services into the home rather than go into a facility? If you've been around Long Island and you've seen all of the over 55 and assisted living facilities popping up and a lot of development in that area. So we're thinking at Northwell, what do we have to meet this need and what are our gaps? What do we need to develop and what is our strategy as this, what we have affectionately called the silver tsunami comes our way. So I'll talk just a little bit about the skilled nursing facility space. Historically, this was a focus area where we were looking at a lot of orthopedic patients, neuro patients. They had long lengths of stay, and there was a lot of long-term care as well. And there was more demand than supply. There was waiting lists to get into facilities. And now, due to a lot of the changes that Merrill mentioned, there are more clinically complex patients coming to skilled nursing facilities. They're kind of akin to what a community hospital used to be 15 to 20 years ago, the types of services they're providing and clinical services they're providing to patients. Patients are having shorter lengths of stay, and there's a lot more supply than demand, a lot more beds than demand for services. And this was only fueled by the pandemic. Vacancy rates at nursing homes are at an all-time high. People do not want to be in nursing homes. They want to be home for various reasons. And this just really accelerated that, that trend. So at Northwell, we have 3 facilities that Merrill mentioned in Manhasset, Valley Stream, and Riverhead. So our strategy for these sites is how do we differentiate ourselves in a market that's oversaturated with skilled nursing facilities? So we are strategizing to make these destination rehabilitation sites where we are enhancing our clinical capabilities with some of these services listed on the slide. And we're partnering with entities, accountable care organizations, both within Northwell and external to Northwell for risk-based arrangements where we can differentiate based on quality and become a short-term rehab destination facility. And we also have a very robust at-home program that Merrill gave a nice overview on. So a little more detail. We have Northwell Health at Home, and we are the largest integrated continuum in New York. Many of our other health systems in the area have maybe pieces of this or they partner for this, but Northwell is unique in that we have the whole continuum, everything a patient could need, and they can have all of that care coordinated through Northwell, connected with their physicians, and if they do have to have a hospitalization, everything is coordinated and connected. We have our home health, which is just traditional short-term intermittent care. It is a nursing agency, also providing physical therapy, speech therapy, OT, and social work. We have a home infusion company, which provides high-tech nursing, along with a state licensed pharmacy, providing home infusion, antibiotics, chemotherapy, hydration, things like that. We have a licensed home care agency, which is our paraprofessional arm of Northwell at Home, providing home health aid services, both through managed long-term care programs and also a private pay arm of that, as well as a geriatric care management program, which is a social work program for social workers who specialize in geriatrics, and they coordinate for their clients or the adult children of clients who will reach out for this service to coordinate all aspects of the client's care, from medical coordination to non-medical, more social determinants of health type of activities. We have a new offering that was spurred by an increase in demand for rehab at home. So as patients don't need home health or don't qualify for traditional home health and really need outpatient level of therapy, but are either unable or, like the pandemic, really unwilling to go to a facility, we've brought that care to them in the home. So this is outpatient level of care, but in the home setting for rehab. And we have a hospice, which 90% of our hospice is in the home, but we do have an inn in Melville and inpatient sites connected to some of our inpatient facilities. We provide service in a very large geographic area, from Westchester and Putnam, the 5 boroughs, and all across Long Island, with 7 offices that we coordinate care through. On any given day, our average daily census of patients on home-based care is almost the same, if not equal, to the number of patients in Northwell hospitals. So our hospital beds equal our at-home daily census. And we've described our new offering meeting the demand for in-home services. We're seeing more people want different services than the traditional core home health in the home. And this really enables patients to stay connected to Northwell along the continuum and really completes that gap. We have been focusing on a lot of specialty and disease management programs that are in alignment with what the community needs as they age, as well as pediatrics. And this also aligns with the health system's strategic initiatives and all of these programs are clinically integrated with both the inpatient teams and the ambulatory teams. So the clinical program is seamless from inpatient, ambulatory, and home-based for these patients. And as this population ages, we're seeing a big increase in demand for services that enable patients to stay home and stay home independently. So we are looking at this as a strategic opportunity in the private pay market to create an offering for aging adults to stay home and coordinate all of that service for them, whether it is medical or non-medical, and do it all through one place. And we think that technology is going to be a major piece of this, where we can use technology to wrap all these services around the patients. So this is something we're actively working on and we're very excited about. And we see that a lot of the adult children of our patients who are either out of state or in state but working and don't have the ability to manage the day-to-day activities of their patients are really, there is a demand from that population as well. So not only do we offer these services across the continuum, but we focus on the end of life and palliative continuum and integrating that offering for patients from the outpatient setting to nursing home, where we have palliative care and inpatient beds, to physician offices and in the home. So we are connecting this care across the continuum so that as a patient kind of progresses along the palliative and end of life continuum, it's a seamless approach for them and for their care. During COVID, we saw the value of having at-home services. We treated over 4,000 COVID patients at home. We had a very robust program partnered with our pulmonology department to keep patients home and prevent hospitalizations by coordinating DME, like home oxygen, doing home infusion of remdesivir, and trying to keep those patients home to create more capacity in the acute care setting for those that really needed it. And telehealth was a huge part of that. We've always had a small telehealth program, but due to some reimbursement issues and operational issues, we weren't able to grow it. But during the pandemic, as a lot of people know, anything was possible that you never thought was possible in the past. And we provided over 13,000 telehealth visits, which really enabled us to expand our offering to patients to make sure that they had frequent touches as we prevented hospitalizations. It expanded our workforce capacity and to keep them safe and prevent the risk of infection or quarantining, which would then put a stress on our workforce. So the value of having all of these services in one continuum attached to Northwell, we have a lot of what we think is a very positive impact of keeping patients home as we meet the need and the demands for them to want to age in place and get their care at home in the right setting. We think that home-based care is a huge component to managing a risk-based arrangement with a positive impact on quality. And all of these services are allowing Northwell to be very innovative and flexible in care models, whether it is from new payment models or something like a pandemic where we really were able to pivot and provide a huge value. We support Northwell by keeping everybody connected within their doctors and their systems, not having to go outside of their care team for their home-based services. And that's it. I think I'll hand it back over to Senator Hannon.
Well, thank you, Meredith. That's the quickest I've ever seen 20 slides discussed, and it was very clear cut. I'm especially overwhelmed with the fact that you can equate the number of people in your census with the number of hospital beds in the system. That kind of gives you an indication of what a coming movement it is to do care at the home. And especially when you only started rehab in a couple of years ago, because other people have been doing that in the home for a while. I'm not going to ask people to, if they have any questions, to make them now. We'll be certainly to take them after. Just enter the question in the chat and I'll be happy to respond, because I'd really like to get more questions. I wrote down a number of things myself. And also, Meredith, thanks for not introducing too many acronyms that people don't understand. They're kind of an affliction to healthcare. Directly switching to Carol Waldman, and directly intentionally switching before we get to Al Cardillo in regard to the general statewide picture of healthcare. I wanted to say there are other ways of addressing the needs of people who are seniors or homebound. And that would be through what we had as a very rigorous and rich system of senior citizen agencies on Long Island, probably more so than many other parts of the state. They've been part and parcel. They run, many of them run through the cities. We have 2 cities, through the townships, and give an outreach that we really haven't realized how rich it can be when it comes to taking care of folks, having someone watch for them. Carol has been working, the Senior Citizen Director at Glen Cove, a very vigorous, proud city on the North Shore of Long Island for over 3 decades. You claim to be retired, but after chatting with you, I'm not sure where that comes from. Carol, I'll give you the floor.
Thank you so much. I'd like to talk about many different things, but I'd like to start by discussing community-based services and the potential support that they offer to address long-term care needs, after I talk about the fact that many of these long-term needs are actually preventable through community-based services. And that's a very important fact that I think we have to keep consideration of. If we want to look at the whole journey of aging, planning and prevention driven by community services really can play an incredibly important role in healthy aging. One of the best examples that I can give you of this is in fall prevention. Many of you know that there's been an increase in the death rate of older adults from falls by 30% in the past 15 years. And if this rate continues by 2030, there will be 7 deaths from falls every hour. About 36 million older adults fall each year. 3 million are treated at emergency rooms, and 300,000 are hospitalized for hip fractures. We know the trajectory of this all too common scenario. There is a fall, a break, and then a life that quickly or slowly begins to unravel. But falling is not inevitable if risk factors are identified and addressed. And here's how our community in Glen Cove responded. We created vision screenings regularly at the Senior Center in partnership with our local Glen Cove Hospital, Northwell, and businesses that do community service work. We created exercise programs that expanded beyond strength training to do Tai Chi so that seniors could focus on improving their balance. We created a lending library of canes and walkers for those who were feeling a bit vulnerable and unsteady on their feet. Our youth bureau developed a snow shoveling and yard work program so that seniors wouldn't slip on the ice in the winter or the wet leaves in the fall. Public Works committed to addressing curb cuts, potholes, broken sidewalks that were identified during town hall meetings. Parks and Recreation cut shrubs back and made cleaning paths a part of their everyday responsibility. The Community Development Agency at Glen Cove made home modification grants a priority and available to those over 60 so that items like grab bars and ramps could be installed for those who couldn't afford them. The timing of some of our traffic lights was adjusted to give those with disability the chance to cross the street safely and without rushing. The Senior Center even advocated for a navigator to be installed to help those who were visually impaired crossing the street. Our EMS decided to offer free home assessments to help people make their homes safety-proof from falls. And hospital staff, environmental gerontologists, advanced nursing and physical therapy students from many universities were invited to give lectures on fall prevention and do assessments of city buildings. The statistics that I mentioned earlier were countered by the many community-based efforts because statistics really represent people's lives. And because if we did our jobs well, people didn't become statistics, they remained vital with the potential to thrive. Social isolation and loneliness are yet another example of conditions that can have devastating and long-term effects, but in fact can be avoided if one is aware of and able to access existing community-based services. The Senior Center and staff and volunteers at the Glen Cove Center provide friendly visiting, telephone reassurance for those who are homebound, and together with the local hospital, created the ROSE program, which is reaching out to seniors every day. If it was understood that someone was having difficulties managing by themselves, a referral could be made to the center's social worker for case management support or to the city's psychologist for mental health assistance. I cannot tell you how many potential catastrophes were avoided because these efforts were in place, particularly during the pandemic, but prior to it as well. But that being said, there are many instances when the need for long-term care is unavoidable. It's estimated that about 70% of people 65 and older will require a higher level of long-term care, and about 1/3 will need it for at least 2 years. That's when community-based services become even more critical, and that's when community becomes family. So what services are needed for long-term care? Most of us know them inside out: nurses and occupational and physical therapists, assistance with personal care such as eating and bathing, help from a care manager, attendance at an adult day program for the individual coping with physical limitations and or cognitive limitations, and critical respite for their caregiver. Help with chores such as cooking and cleaning, transportation, and home repairs. And while Medicaid provides strong support in many of these areas, not everyone meets the eligibility requirements for Medicaid services. And while personal long-term care policies often include these services, not everyone is wealthy enough to afford that. Those with limited income that are over 60, but who are not eligible for Medicaid, but who are in need of help with daily activities of living, can take advantage of the state's ISIP program run through the area agencies on aging. This is the expanded in-home services for the elderly. This program provides non-medical services such as personal care, transportation assistance, and case management. And back in 2011, some changes were made to the program to allow for consumer-directed in-home services where the recipient can select, train, and manage their own care providers. But consumer direction varies from county to county, and it's a cost-sharing program and provides support as long as it doesn't exceed the cost of nursing home care. Currently, there is a waiting list for ISIP services here in Nassau County, but primarily because there's a short supply of trained and available healthcare workers. Hopefully, under the $2 trillion infrastructure bill that President Biden is proposing, his $400 billion investment in expanding home and community-based support systems will address this issue. But what's not clear is whether that money will be spent on strengthening the workforce, reducing the waiting lists, or enhancing the services. Hopefully, all three. But while that is being considered, Glen Cove has, like a few other communities, have a few community-based projects that lend support to alternatives to nursing homes. They provide medical transportation through a core of dedicated volunteers that has been invaluable to residents who don't drive but need access to medical treatment and doctor appointments. And the city offers handicap-accessible loop bus service that circles the city throughout the day so residents can do their food shopping and reach their doctors, stop at the library, or visit their senior center. One new initiative that we're exploring that I am very excited about is time banking. This is a program that's been in existence for several years, but with the help of the chair of the School for Health Professionals at Hofstra, it is now being established in Glen Cove. The concept is that we all have something to offer one another, and that money is not the only currency that has value. It relies on my ability and desire to provide volunteer support to you. That could be in the form of picking up your mail or your medicine, teaching you how to use the internet, cooking you a hot meal, or replacing a light bulb and a smoke detector. For every hour spent offering support to someone else, I get an hour of credit that I could use when I need help. These hours are banked and can be used as needed and does not have to be reciprocal involving the person that I helped. So if could be services from someone else, someone who could bake cookies for my granddaughter's birthday party, or could read the newspaper to me, or translate a letter. The thing that I love about this program is that all services are of equal value. The time it takes for me to teach you a new language gets the same value as the time it takes someone else to pick up groceries for me. And as long as long-term care needs grow, time banking can be an invaluable asset to any community. Areas like the town of North Hempstead have a program called Project Independence, which operates a 311 call-in system that directs seniors' needs to the appropriate office or service and does intensive follow-up to make sure that issues are resolved. It has been wildly successful in helping seniors age in place and should serve as a model for other communities. And then, of course, there are the NORCs, the naturally occurring retirement communities that partner with not-for-profit organizations to provide assistance in remaining at home as well. But NORCs are limited to buildings and communities that have a large number of older adults. And not every community that has those large numbers is lucky enough to get competitive federal support. I believe the most effective way to build community support for long-term care needs is not just to strengthen the aging community, but to expand it to include all people. And that's why I'm such a strong advocate for the age-friendly movement that is growing across the country. It looks at 8 domains: housing, transportation, health and community service, open spaces, social inclusion, civic engagement, and information and communication. And it correlates to the social determinants of health. And it asks questions like, do communities have healthcare facilities, a hospital, urgent care, pharmacies, and are they accessible? Are buildings being built to accommodate universal design? What's the lighting like? Are streets safe and walkable? Are there alternatives to driving? Is there truly affordable housing? Are there benches for resting and bus stops covers in case of long waits in the cold or in the rain? Are there opportunities to engage at all levels and for all people? Are people whose first language is not English considered? And are events and programs and services geared to all ages and ethnicities? And what are the emergency services like? Are community leaders aware of residents' concerns, particularly those with limitations? It asks us to coordinate from the top down and the bottom up, and to have all residents and community leaders focus on planning and policies with an age-friendly lens. Can people grow up and grow old here safely and vibrantly and with supports in place? And lastly, I just want to emphasize how important it is, as you mentioned, to invest in senior centers and social model adult day programs, because they not only provide nutrition, socialization, stimulation, advocacy for members, but respite and support for caregivers. Every community should have a senior center and a continuum of care. Senior centers should be centrally located and housed in an adequate ADA compliant building, whether it's shared or a standalone, with air conditioning and with heat, and with Department of Health approved kitchen facilities. And most importantly, a social worker to provide information, referrals, case management, and counseling. We need to, of course, invest more in programs like ISIP and nutrition programs for the homebound like Meals on Wheels. And finally, there should be better coordination with hospitals and rehab centers in terms of discharge planning so that the transition to community-based services is really effective. This means that institutions and organizations cannot operate in silos. We must work together and follow a resident from one setting to another with thorough coordinated care and a compassionate and gentle handover that best meets their needs. Thank you.
Wow. You've generated a few questions. I won't pose them to you right now, but you think about it, they both center around Medicare. With that, and that's exactly precisely the point I wanted to make. Let's go back to the organized medicine part of this. Al Cardillo, who is head of the Healthcare Association of New York, has had a number of distinguished policymaking positions in the Senate. We didn't actually overlap in the same time in the Health Committee, but he preceded me and set high marks for what could be done and had to be done. And now with the Healthcare Association, all of the things that are done in one place by Merryl Siegel at Northwell, he's coordinating on a statewide basis with CHAs, with LICSs, with MLTCs, and with the entire alphabet range of agencies. Al, maybe some thoughts on our topic, and I think you have a presentation also.
I do. Thank you so much, Senator. Thank you, Dean, Tony, and distinguished members of the panel. I think those presentations were really just incredible, in depth. You rang so many bells. I feel like if we could huddle and have a session right now, we could probably come up with some really great stuff to take statewide. Let me share this presentation with you. Some slides. Okay, so I'm gonna focus, as the senator said, on statewide, some of the statewide, the landscape and home care, some of the directions, and even include some references to where things are federally, as was just alluded to. Just, our association is a statewide association that we have all levels of the services that were talked about today. We have indirectly the aging services that are through the locals, but there's a great deal of interface between the home care agencies, the AAAs, and of course, Northwell is a very prominent provider member within the Home Care Association. So home care, hospice, managed long-term care, all the waiver programs and services that serve hundreds of thousands of people annually. Just to review the core infrastructure of services in the state in home care: certified home health agencies, licensed home health agencies, long-term home health care programs, managed long-term care plans, hospices, home and community-based waiver programs, consumer-directed, and then, of course, all of the surrounding aging support services, as Carol really just so eloquently discussed. This gives you a little bit of proportion. Home health agencies, so certified home health agencies are certified to participate directly in Medicare and Medicaid, and also in most insurance, although insurance coverages are limited. There's about 114 in the state, and the size and scope of the system is changing all the time with mergers, acquisitions, openings, closures. So currently we have about 114 certified agencies, and one of those is Northwell. Licensed agencies, about 1,400 of those agencies. That number's a little inflated because if you're an agency and you operate 7 branch offices, that has to count as 7 licenses. So in actual fact, there's probably a little under 1,000 that would form what's the licensed layer. Those are state licensed, not federal. Licensed agencies generally contract with certified agencies, contract with AAA, area agencies on aging, or managed care plans or hospices. 42 hospices in the state, 14 of long-term home health care programs, and managed long-term care plans, currently about 37. So if you look at the magnitude of patients, over 700,000 patients are served by home care and hospice providers. There is, by some estimates, some projections, over 400,000 home health and personal care aides in New York. That's a federal number, which we think may have some double counting. So for purposes of really perspective, somewhere between about 250 and 450 is the representation of the home health and personal care aid workforce. There's additional programs, as we mentioned, and they're statewide: the consumer-directed program, the waiver programs such as traumatic brain injury, nursing home transition, care at home, or the Katie Beckett programs, and then allied services and supports. So who provides home care agencies? There are freestanding entities like visiting nurse services or public agencies or independent private agencies, hospitals and health systems such as Northwell, nursing homes, and actually there are some insurers that sponsor home care programs. Home care providers and hospices, as I mentioned, are state and federally certified. Licensed agencies are state licensed. And one thing that's important, and just worth mentioning that, is because for agencies that directly participate in Medicaid and Medicare, just like hospitals, they're under a bevy of regulation, both federal and state. And as we talk about how to provide services in a truly patient-centered way, one layer of thinking is really to sort of think beyond the box. This is the home care box, this is the hospital box, this is the clinic box, and how do we really take services and really orient them whenever the patient needs them to their needs? So it's like applying the best tool at the right time and in the right circumstance. Those regulations are not always easy to navigate, and that creates issues. And I know Senator Hannon just referred to Medicare and the implications of Medicare. Okay, this is a snapshot of the home care continuum, so that you can really see the full breadth of what home care does. Home care is often thought of as a geriatric model, and perhaps a model that's exclusively focused on meeting ADL needs, chronic illness needs. But in actual fact, home care really spans the continuum and operates in the primary care space, the post-acute space, the long-term care space, and within, you can see within this graphic, the different populations that home care serves, the different functions it plays, and I'll talk about that further in the slides. I think as we go forward, what is a very positive and I think progressive direction to go is, I say, to consider home care's role anywhere within this continuum, and how, as a partner with doctors, nurse practitioners, offices for aging, hospitals, and other settings, can home care and those other partners really best meet the needs of the patient and operate really the most effective system of care. So as we were saying, home care really crosses the spectrum in terms of the clients. So there are new moms and infants served in home care, children and adults with public health needs, medical fragility or disability, individuals with mental health, seniors that need help with activities of daily living, post-surgical patients needing assistance with wound care and recovery. You heard some of those services in Merrill and Meredith's presentation. And then individuals with complex medical conditions that really require a lot of in-home skilled monitoring or management. The services that are provided also go along the continuum. So they include care management, nursing, physical therapy, occupational therapy, speech pathology, medical social work, audiology, respiratory therapy, nutrition, the services that support the person on a daily level, like home health aid and personal care and housekeeping, technology and telehealth, which are services that are growing in terms of their role. And I would mention that Senator Hannon was the sponsor of the country's first statewide Medicaid telehealth program being provided in the home, and pioneered that in 2007. So we were way ahead of the rest of the country on that. And that continues to be an area where technological applications are really creating some major capabilities in terms of both prevention and management of patients at home. And then of course, there's the wraparound supports and services, adapting the home, delivering meals, integrating with social daycare, medical supplies and appliances, and so on. Those services are important. Senator Hannon talked about the social determinants of health. You know, those services are important because it brings about and requires a different perspective on the care of an individual. So that, for example, if you're an agency and what you do is provide human intensive services, and somebody needs help, for example, transferring, getting in and out of the bathroom, meet with meal preparation, the thought could otherwise be the aide will come and the aide will help you transfer, the aide will prepare the meals, assist you in stability and so on. But a broader perspective, a more patient-centered perspective is what is this patient capable of doing if we support that individual, that supports their independence and their dignity. So adapting the home, adapting that environment for safety and for capabilities for transitions. May be much more precisely what that individual needs, and then say combined with a delivered meal. And we'll talk about some of these other services later on in the presentation as well. But again, very important to really conceptualize in a comprehensive way the match between assessment, services, and really a plan that's tailored to the needs of the patient. So patients overwhelmingly prefer care in the home, and there's survey after survey that reinforces this. 90% of people would prefer to care for themselves in their own home. Nearly 1 in 6 New Yorkers are now age 65 and over, and Meredith had some excellent stats on that. On average, 52% of people who turn 65 today will develop a severe disability that will require long-term support at home at some point, accounting for 2 years of care over a lifetime. Also want to emphasize, and we'll get to this in a slide, that when you look at the ages, and here it is, it's the over 65 population is clearly a focal point, but the over 85 percentages, that's really the focus of where utilization is occurring, where need becomes really more, on a more daily, more critical basis. And the increases in the over 85 population are substantial and will continue to go up. And that really heavily determines, an individual's need for services as they continue to age. As Carol had said, a great goal for our system and our society is how do we organize our services and our structures to have people live healthy, productive, quality lives, even as they move through this age continuum. But this certainly depicts what is an ever increasing demand for care. And in the pandemic, this has completely surged. The increases in referrals from hospitals with increased complexity and of individuals that have sort of rediscovered the fact that they would want a home care option. Again, that has just become so prominent in the aftermath of the pandemic. Another indicator is the workforce. And of course, in this field, you have to have the workforce. It's the core of what you do in the care of the patients. Home health aides and personal care aides alone, this chart really shows those projections. The increases in projections in these occupations are really at the top. It's the fastest growing employment group in the state. And in most cases, when you look at national figures, it's really right at the top. This is an indication of demand, just like the prior slide is, need and demand. And the challenge before the system is, can we recruit and retain and support a workforce of a sufficient nature, sufficient quality and competency to meet the needs of this growing population? Right now, we are in a situation where the gap between the resource and the need is growing wider and wider. And in the pandemic, it's really an emergency proportions. So where next with home care? Well, the crisis has not only spotlighted the value and desire for care at home, but really, as I mentioned, has really driven it into unprecedented levels. And so the focus on investment in home care is probably at a 40-year high. You know, when I came into the system, which I don't want to say, but it was a little over 40 years ago, home care was the focal point. The growth and the development of home care was the focal point to sort of stem what was the trend of individuals going into long-term care and addressing demographics. But not since really that period of time has the focus been this intense. You know, when we hit the 90s, we really hit late 80s and 90s, a period of Medicaid budget snags, federal snags, and that really sort of weakened the investments. But like a comet, as a comet returns, home care is sort of on the rebound. So we have this driving demand for care at home, but we also have state-of-the-art medical practices that are increasingly recognizing the value of care at home, and where home care is a key partner in roles. And I was just so impressed with Merryl and Meredith's presentation, because they really crystallized that, how the hospital and the home care agency are working together to really fulfill the needs of the community in a very partnered way. And here you see on this list some of those areas where home care has a very important, not only significant role, but I think significant potential going forward. Carol talked about falls, and falls assessment and support for falls prevention is another really critical area. And we could go on in that, but you can see that going along with the idea of using a venue like home care as a tool, rather than as, okay, you're in the home care box, or you're in the doctor's box or the clinic's box, I think is an important paradigm. What we are doing is we're advancing a proposal in the New York State Legislature and in government for something we call Home Care First. A home care first policy that ensures that home care is a principal option for patients wherever they are in the continuum of need, and certainly when they're facing institutionalization, and that it should be available it should be available when those needs occur, and the policies that govern home care, whether they're regulatory, fiscal, workforce related, reimbursement, they should really all be aligned to support that kind of a goal, so that we don't have a paper program. We have a program in reality that can really work to meet the needs of patients. Going to the federal side. So, you know, with the spotlight, not just at the state, but at the federal level, currently 1.6 billion has been inserted in the state budget, but derived from federal funds, federal additional matching funds coming to New York, which the health department believes can increase to $5 billion over several years. That's all to support home and community-based services, some in traditional home care, others in mental health, substance abuse, developmental disabilities. Also been discussion of billions in federal home and community-based services reinvestment. Unfortunately, the latest iteration of the Infrastructure Act does not contain the $400 billion that the president proposed. That's not in the act. But there's an opportunity for that to be revisited to some extent in what may follow the infrastructure deal, depending on how that gets done. Another really a new initiative, this is really hot in terms of the development, is something called the Choose Home Act, which is a bit like a federal version of the Home Care First that I just talked about. The simplest way I can describe the Choose Home Act for you is similar to what we used to have in New York more prominently as the long-term home health care program, where we just have some residual sites now, but it would basically be like a long-term home health care program under Medicare. Not the same length of sustainability of services, but extended care, expanded services, and expanded circumstances in which those services could be provided. Definitely breaking the current barriers of the Medicare home care model. There was the WISH Act, which is actually something sponsored by Congressman Swazi that would create an insurance program through a payroll deduction plan to cover long-term care, and a piece of legislation called the Better Care, Better Jobs Act that would be looking to put some major funds into Medicaid, largely to support the workforce, but also into other areas. And the question is, how will all this emerge from the current federal environment, which is, it's a pretty cloudy environment right now, but I think the bets are that there will be some major action coming federally. In terms of innovation, so again, we could talk about this forever, but in terms of innovations, here are some examples. We've been working for the last 2 years with the State Hospital Association and one of the other regional hospital associations on something called the Statewide Hospital Home Care Collaborative. Northwell Health was a feature in terms of their collaboration in the models that we are trying to present to hospitals and home care partners and physician partners around the state, encouraging integration. And I think that Meredith and Merryl indirectly referred to the Crowns and the CARES program by referring to the extent to which they were caring for over 4,000 COVID-related patients at home, in that kind of collaborative. Two others I just will mention to you. One is the University of Rochester has created a critical illness recovery program. And in this program, critically ill patients are reconceptualized from the critical illness period and discharged to home to viewing the patient across an entire episode where they may need services, with the presumption that upon discharge, there are exacerbations that occur, sometimes weeks, even months after that discharge, but all related to the critical illness. And so in this program, again, if you were to define an episode from in-hospital to in-home and bring a team of hospital and community providers, practitioners together and manage that from the get-go and coordinate, that's what that program is all about. Gerwin and Stony Brook are also, they have an integrated program where they're utilizing Bluetooth technology to monitor patient vitals, report back to the physician, and again, coordinate across the community. Carol, you talked about loneliness and isolation. Another innovation, and all these are accessible on this site that you see in the slide. There's an initiative through the Self-Help Community Service Program, which is in New York City and also serves Long Island. That they have a platform called the Virtual Senior Center, which actually brings a group environment to individuals who are isolated in their home. And the group, and in that group, you receive services similar to social daycare, but there's cultural enrichment, self-care, education, all sorts of things. We have grants from both the Cabrini Foundation and the New York State Health Foundation to expand that platform so that any provider statewide or any consumer would have the capacity to enroll in that program. And more information would be available to you. But again, a direction of bringing the social determinants and the physical side together, recognizing the care of the entire person and doing so through technology. I'll just mention these last things briefly. Home care sepsis screening and intervention. Most people, when they think of sepsis, they think about, well, that's something you get in the hospital. But the reality is over 90% of sepsis occurrences are at home and community. And the patient lands in the hospital because of the failure of the family or the failure of the system to have recognized signs and symptoms. So over the last 7 years, we've worked to create the country's really first statewide home care sepsis screening initiative for individuals who are receiving home care who are among the highest risks. Dr. Martin Dorfler from Northwell was a chief advisor in that. And so that's another area where, again, working together, you really can have an impact in an innovative way on what really, in the case of sepsis, is the #1 killer in hospitals, the #1 national cost in hospitals, and the #1 cause of readmissions. And I think I'll just stop there because I think I went into a little bit more detail than I intended in some areas, and I want to make sure to leave time. And I think that was my last slide.
You must have cut one out. Thank you. That is a lot of detail, and frankly, that's a rich set of resources in order to mine later on. I want to give you a kind of a trick question because Ms. Waldman's mention of ISIS reminds me that when we were doing the state budget and we'd have a little money left over, and believe it or not, sometimes we would have a little money left over. The money would be in the order of $5–10 million. Now, putting that into any institutional setting meant that it would quickly get exhausted. So we would try to think of what could we do, and we'd put it to senior citizen programs in the counties, knowing that what was done in the ISIP program could give you bigger bang for the buck. It would give you more care in the home. It would give you more meals in the home. And whatever it was, and certainly all the counties had different ways of implementing it, it found its way into the field very quickly. Contrast that with what you've been describing and what Merrill's been describing, what they do at Northwell. There are so many entities. At one point in Meredith's screen, each one of the balloons across the screen, I think there were 5, was a licensed agency, whether it was whatever it was. And I'm thinking, have we in the state of New York over licensed things? I know there's a battle with the licensed home care agencies, the CHAs. Do we make it too difficult to get care out to the field because there's so many license impediments? And so it's a joint question to Merrill and to Al. Merrill?
So I think the answer is yes. It's very highly regulated. And one of the reasons we had the vast array of services is because we can coordinate through our different entities together and case manage the case. But the licensed agency is separate, has separate regulations from the certified agency. The reimbursement mechanisms are different. The coverage is different. So it really makes it difficult to provide a comprehensive array of services to a patient, even infusion. So there could be a particular case where the certified agency, the licensed agency, infusion are all providing services under separate licenses and separate reimbursements. So yes, it makes it very difficult for a patient to access. And plus it's confusing to the consumer because they don't know which services are covered, what services are not, what has co-pays, what is going to be privately paid. So it's a very difficult situation. And I think it's nationwide. My counterparts in other states are experiencing the same issues.
Yeah, and I think it's it's going back to what I was saying. It's the creation of nice little boxes, that fit these various categories, and each of them carry these regulations. But then in the end, the boxes really interfere with what makes sense as far as a seamless system to try to deliver services to patients. We have the state layer of the state regulations, the federal regulations, and then because the state is required mandatory enrollment managed care, for at least for the Medicaid population, there's another series of standards and regulations and protocols that all relate to that. There was a time, it was before 1985, and there was no such thing as a licensed agency. There were certified agencies. And if you were an entity that provided services in the home, staffing, you contracted with the certified agency and you lived and worked under their standards, but there was not a separate licensure. There was not a separate set of, let's say, directives on you distinct from the certified agency. The state decided in the mid-'80s that any entity that provides care in the home should meet a minimum standard, and that's really where licensure came from. It's not recognized by the feds per se, and most other states do not have that model.
One of
Add
the,
that, if I can, just want to add that the complication for the community-based services like senior centers, who tend to be the very strong advocates for people going through the services that you're talking about in the agencies, we don't know how to come at it. It's so difficult to navigate to try to, to advocate for a patient. And that's another complication to it.
one of the most interesting visits I had by people from a hospital lobbying was when they told me about how they were taking care of people who were discharged from the hospital and at their home. And they said, we're just sending doctors out to make sure they're okay. I said, wait a minute, why would you do that? You're a big hospital, you have a home care agency. And they said, the regulations are so complicated that even though we're paying the doctor, it's easier for us to do it this way than to go through the home care agency. And it was a pretty well-renowned home care agency. So it's this always all leads me to the fact that when we have a shortage of workers, how much are we paying, so to speak, for the workers, because we have to pay attention to so many different silos that's going on.
Yeah.
Let me switch a little totally different thing that's been bugging me as I've been reading the paper lately. And that's the question of penalizing people in healthcare who don't do well. Now, you will find any number of comments that are down on nursing homes. And in fact, probably it's one of the reasons our nursing homes have a low census. And if they continue to have a low census, they may not continue to be financially viable. But the question would be, in my mind, there are nursing homes who did pretty well during a terrible pandemic. There are others who probably didn't do very well at all. But if there are slight variations in compliance with the regulations, whatever the nursing home is, the penalty is the same. The penalties could be quite severe. In fact, there's a whole thing that just happened with the federal government releasing some of the Trump relaxation of penalties so that they can go back and make greater penalties on nursing homes. But my question would be, isn't there a better way of disciplining, of improving a healthcare system, whether it be home care, whether it be a nursing home, whether it be ambulatory surgery, whatever it is, a better way than simply penalizing? Because more often than not, the entity that's penalized is the least able to afford it. And so the penalty just makes them even less able to afford it. I never thought it was a great system.
And to add to that, that's such a good point. To add to that, what's unfortunate is that these institutions have to play to that penalty. So instead of focusing on the patient care and what's best for the patient, they have to try to think about how they're going to be handled and if they'll be penalized and how that will affect them. So suddenly the patient isn't the most important thing anymore. Or you have, for example, what you brought out before, you have patients who are in rehab centers who are not making either a quick enough or meaningful enough recovery. And if that's the case, then they really can't receive services, or at least the nursing home doesn't get reimbursed for them. What happens to that person? They still need the same care, the custodial care, the nursing care, whatever. But now since they're not making the progress, they either have to pay on their own or they lose out. So you're 100% right. We really have to kind of switch the focus somehow.
I think one of the big moves has really been to move the payment system to be rewarding value, and indirectly penalizing poorer quality, through those devices, by really focusing in on outcomes for the patients that are really better than what the baseline would have been. And I think that's been evident in the managed care system, where you've got several $100 million combined of quality pool funds that are to try to incentivize better outcomes. The federal government, just in the Medicare rule for home care, just passed a requirement that I believe starting next year, the value-based mechanism in home care will be nationwide. And hospice is moving in similar directions too. There was just a hospice rule, federal rule that was adopted that's going to look differently at the way hospice quality metrics are assessed and posted. So I think that's been one of the ways. The other thing is by engaging the consumer scoring and other quality data, which then gets posted kind of a report card on the provider, on the facility, and then that becomes something that influences voting with your feet, influences managed care contracts and other things. That's probably the best I can answer at this point.
Merrill, you've been doing
I think part of the problem is consumers don't really understand how to assess a quality organization. So even though metrics are posted on Nursing Home Compare or Home Care Compare, I think consumers usually go to the place that's nearest to their residents. And so even though we've tried to partner with some of the better facilities in the area other than our own, it's very difficult to determine which how to get patients to move to those better facilities. So I think it stems from the consumer as well as from the regulatory component.
I think that's a great point. And I also think that where, again, community-based services could be of help there is that the reason they choose a facility close to home is so they get the support of family and friends visiting, hopefully, not during COVID
Right.
perhaps, but, and if those family and friends don't have access to transportation that gets them further away, that may, affect their healing process. So, we have a role to play in terms of community-based work to provide more support for people to consider those options and provide better transportation for those family or friends.
I think COVID has really complicated the whole issue because of the visitation issue and because, people just can't get to see their loved ones regardless, given, the strict guidelines that Department of Health has imposed on us.
Yeah, and I was hoping, and we pretty much did, is look beyond COVID, as devastating and as skewing it will be of the healthcare system as we go forward. I'd like to now propose that I get some last thoughts from each of you for a few minutes, and thoughts of where we're going with the non-hospital system or the home care system, and what might you hope for, or what might you want to avoid? I'll start with you, Merrill, and then go.
We at Northwell are still trying to build every possibility of service that can be provided to an individual who wants to remain at home. So we're continuing to come up with new programs, innovative care models, and given the constraints with reimbursement, we're trying to move around that and see how we can provide the best possible service to the largest population that we can in our geographic service.
Well, and one of the things you're doing, which is not under your jurisdiction, is health homes, which was inspired by the federal program. But we tussled with that in the legislature for a while. It wasn't until I got out and was talking with somebody in health homes in Northwell, I found out how well it's done. So it is another variation with a risk-based model, and hopefully it will continue.
Yes.
Al, Carol, excuse me.
Okay. I was just going to mention Al for a moment because I wanted to thank you for bringing up for a moment the information about the self-help virtual senior center. I didn't include that, and I apologize, I should have. Glen Cove did take part. We were very fortunate to be sponsored by them. So we kind of broke the walls down in the center and got into the community as well. And thank you for bringing that up in terms of social isolation. We covered yoga, we covered cooking, we covered bereavement support, all the things that you're talking about that we could have, and it made a difference. So thanks for bringing that up. As far as just to answer your question on final thoughts, I really believe there has to be tremendous nursing home transformation. We've been talking about it for years. I'd like it to go from discussion to reality at some point. That's my hope. I also think, everything that Al described in terms of the legislation that's out there, even if it's not, fully accepted and approved, if people can pay attention to it, I think it will help us educate everyone, the public included, about what the needs are. So I think that legislation is important on many levels, and I hope it gets the attention it deserves. And lastly, I would say the age-friendly lens for me is the lens that should be used for all planning and policy work going forward. I really think it will make a difference, and it will complement all the work that home care and hospitals are doing.
And is there a place where some of the things you mentioned are all put together so people can make choices? I mean, I really wasn't aware of the 311 call-in service, which sounds to me a little bit what you just described as the self-determination senior citizen center.
Yeah, it's Project Independence. It's through North Hempstead. And if you just look up Project Independence, you can find it. But if you'd like me to provide you information, perhaps we can get it out to everyone.
Well, I'm somehow thinking of how to make it wider and broader. And it's not just because in order to look it up, you have to know it exists. And
Right.
in order to know it exists, you have to have kind of a sense of someone promulgating it. And what my thought is, with all the very valuable services that are done through senior citizens, how many of those would supplement what's done through home health and obviate the need for home health and not require a new funding stream?
Exactly. Yeah, absolutely. It is all about education. I think they do at North Hempstead, they do a really quite an excellent job of promoting what they offer. But as far as it extending out beyond, I know that various Congress people, including Congressman Swazi, is really pushing that what is going on in North Hempstead is really valuable, and perhaps every community should move in that direction. So, we'll be working on that for sure.
Thank you, Carol. Now, Al, you've always wanted to hear this. You have the last word.
Thanks, Senator. Well, I kind of go into some of the points that have been made. I mean, I really think that we need to start breaking down the barriers, the structural barriers in the system that exists. It's like you have a puzzle that you need to go together. When the puzzle's together, it's the patient, but the parts really aren't fitting because there are parameters that are created that make no sense. So as an example, the Medicare home care benefit was created in 1965. It's barely different today. It may be paid differently, but it's barely different today in terms of what it's covered. Think about what the age level lifespan was in 1965, what the technology was, what public health was. There's no resemblance to today, and neither does the hospital system that existed there today then now. The state insurance laws that govern coverages for home care were written in 1972. They have never been substantially updated to mirror how could home care be provided today more seamlessly with the needs of the patient. These are just some examples. And then we talked about the regulatory structures and like that. I think where we really need to go is we really need to figure out how we have the professionals, we have the services. How do you organize them around meeting the needs of individuals in a way that truly responds to those needs and is effective? And then thinking about, Carol talked about reforming, on the way we think about nursing homes. The area of housing has been totally, left out of the equation time and again. And to think about how do you integrate housing, the social determinants, and the healthcare services together so that we really can offer these kinds of alternatives to individuals. I think the system's got to be made more flexible, and there's got to really be a focus on it, with the result really being a patient-centered result. And I think we need to look at curriculum. We're at this wonderful institution, the Hofstra. We need to look at what are the curricula, what are health professionals learning as we prepare them to go out in the environment, and is that level of learning, is that skill development something that takes us into this future that we all see? So I'll just.
Well, thank you. Well said. Well said. Each of you, Merryl Siegel, Carol Waldman, Meredith Desor, Al Cardillo, I thank you for spending the time to prepare for this, for your informed comments, and for joining with us today. I thank all of the people listening in. Appreciate your attendance and your suggestions where we'll go. And So I wish you all a good day.
Thank you.
Thank you for having us.
Thank you. Thanks. It's been a pleasure.